Welcome to It's Beyond the Food podcast. I'm your host, Stephanie Dodier, non-diet nutritionist and founder of the Non-Diet Coaching Certification. This is Beyond GLP-1, the Expert Series. I created this series of podcast episodes because informed consent required the full picture, not just the press release. So over the next several episodes, I'm bringing in experts to cover every angle: science, marketing, side effect, impact on body image, nutrition, health, counseling, and what all this means for you and your client. Whatever you are, a health professional navigating these conversations in your practice or someone personally researching your decision, this series is for you. Ready? Let's do this. Welcome to the podcast, Erin.
Hey, thanks for having me.
I'm going to quickly read your bio and we're going to get right into the topic because we have a lot to talk about with food noise. So today we have Dr. Erin Knopf, a triple board certified physician in pediatric, adult psychiatry, and children and adolescent psychiatry. And she's a certified eating disorder specialist, and she's the co-founder of VERY, Virtual Eating Recovery for You. I love this acronym, by the way.
Thank you.
Multidisciplinary outpatient eating disorder practice. And obviously our topic today is going to be everything about the brain, right? So we're going to go in the depth and the throes of food noise. But I'm going to ask you this question because that's what I asked everyone when we started this series. From your seat in your triple board certified specialty, what would you say we're missing when we think about GLP-1 in 2026?
Oh,
I know.
how much time do we have? Truly. What are we missing? I think we are missing everything about holistic healthcare. I think GLP-1 prescriptions and, provisions is really just looking at one outcome, is their weight loss. And then people are either responders or non-responders. They're not actually looking at the whole person. When people talk about GLP-1s will improve quality of life, they're really talking about just giving in to weight stigma and reducing discrimination by being in a smaller body. We're not really talking about how much discrimination truly exists for individuals in larger bodies. It really is as ubiquitous as racism, but at least racism is something people know they shouldn't really admit out loud. But when it comes to healthcare and weight stigma, no, it's normalized and the degree of harm is minimized tremendously.
I love this analogy because that's what I say as a fat person. I say to people, like, I'm a victim of oppression in the same way that people of color are. But the difference is in today's world, it's acceptable for people to treat me the way they do because I'm fat versus discrimination of other groups of people. So that's
correct. And exactly. And this has been something that has been building up for, truly we can at least say the last 100 years, but we can go back even further. We know that there are racist origins into why there's so much fat phobia and weight stigma. But at least, in American history, we know it began in the early 1900s. And it all began when MetLife wanted to create a certain standard of what is ideal health and ideal body size. And that was the first time human beings were actually compared to some standard metric. And then unfortunately, it just ran from there. Now you have the Society of Obesity physicians, and we overly clinicalize the larger body physique. And then you have Ansel Keys, who I have a love-hate relationship with, since he provided so much data for us to better understand how starvation affects the brain and body and long-term issues beyond. He is also the one who said, oh, BMI, great. This equation can absolutely work across cultures and genders and children and adults, when absolutely not. It was a bogus mathematical equation created by a Belgian mathematician and astronomer who was just on a kick to find an equation to describe the ideal European man. So, what?
And here we are today.
In our modern medical society and world, and we are forced to comply with understanding health through this small, narrowed equation. Bizarre. I also find it amazing that somehow correlation and causation has been completely blurred. completely blurred. When I was in medical school, it was always very clear it's correlated. And yet at the same time, we were clearly taught a very stigmatized perspective. It was the assumption that you were implicitly and explicitly taught that someone in a larger body was unhealthy and your job was to help them be healthier, weight loss being one of those mechanisms. When, oh my gosh, there was so much missing. And so this is where I look to my fellow physicians out there. This is not just social justice. And please don't roll your eyes about what's, hip and cool at the moment. No, this is so much more than that. This is about actually taking a critical eye to our education, to our practice of medicine, to our oaths of do no harm, and really rethinking, what are we doing here? If all we can tell someone is, oh, lose weight and you'll get better. First of all, you're not actually reading the literature. You're not actually reading the outcome studies. And you're certainly not reading about all of the harm that happens when you try to interfere with adaptive physiology. That ultimately is the issue here. Weight cycling is harming people more. It is actually probably what is causing high blood pressure, type 2 diabetes, atherosclerosis. This concept of fatty liver disease being something only in a larger body is also bullshit, pardon my French. It actually occurs in thinner people too. So this is all based in rhetoric and narrative, not actual facts. And so you can tell, oh, I'm on my soapbox. I'm
You're
gonna
passive.
bring it back. I'm gonna bring it back for a second. But really, the GLP-1 craze is so scary to watch. It feels like one more example of, snake oil promises of something that it is a global, can treat anything. I mean, the research now looking to see if it can help with completely unrelated systems. This is a metabolic molecule being given to change how the body responds to hunger and satiety, and most importantly, through slowing of gut motility. So we already know what happens with, the term is gastroparesis for those that are more clinically minded out there. We already know the problems with it. And yet it's being normalized and called, these side effects, I'm putting that in air quotes, of nausea and vomiting and constipation, where, those aren't side effects. That is what happens with gastroparesis, period. So if you are supposed to be consenting someone to a treatment and you don't tell them, no, you will have these symptoms in some degree because of how this molecule will work in your body, you are absolutely causing harm and you're not providing ethical, informed consent. So you asked, at the beginning,
A broad
what does this do
question.
to the brain? You
Well, let's
did.
talk
And
about
also, I want to
food
make sure I'm bringing it back
noise.
to the brain.
Yeah, to
Yes,
the
let's do
brain,
it.
because this is one angle that we didn't see coming. Like a year and a half ago, nobody was talking about food noise. It wasn't marketed with food noise, but that's what
Yep.
patients started to express, right? It's not
Yeah.
only making me lose weight, but it's making me lose that constant narrative and obsession in my mind,
Preoccupation.
preoccupation with food. And the marketing term is now called food noise. In my world of intuitive eating back 10 years ago, that was called diet mentality, but it's now being rebranded as food noise. So
Isn't
clinically,
that
can
cute?
you, isn't it cute? Yeah, but it's more marketable than diet mentality. So
Is
what do we know about food noise? What is it clinically? Is there any science behind it? Let's deep dive into that.
So, and this is something that I also want to name. There is an individualized approach to exploring it with a
Yes.
patient or a client. And yes, I have had my own patients tell me, but once that food noise, quote unquote, went away, then I was able to be more recovery focused. Again, we're talking about an eating disorder recovery journey. But truly, what is food noise? It is hunger.
Mm.
It is legitimate hunger. What happens when you physically and mentally restrict, you are now more likely to desire it. If I told you don't think about pink elephants, you are now thinking about pink elephants, whether you want to or not. So when someone says, oh, I don't want to eat chips, for example, I can't control myself with chips, all they want is chips. And then they have this cyclic paradigm that starts to build up through repetitive behaviors and interactions with chips, where they're avoiding it, it's around them. They have a concept of, this is the last time I'm going to allow myself to enjoy this. So I'm just going to go for it. And then having a one serving turns into, nope, I'm just going to do as much as I want. It's fine. And now you've turned it into a binge. And now you've activated the guilt and shame cycle on top of it. So now they start all over again. See, I'm not good with chips. When all along, if there was more emphasis on, I'm always allowed to have chips if I want, it goes great with my ham sandwich. Or when I'm having Mexican food, I love tortilla chips. I can always have them and I'll have them again another time. There wouldn't be this scarcity mindset and fear, shame cycle reenacted over and over again. So, food noise is a result of literal and mental restriction, nothing else really. And if people were not so constantly, I think, guilted into being in this diet mentality of I always have to be limiting either a macromolecule that now is I'm told is not good for me, or limiting the type of foods, whether it's processed or not. The truth is we all need balance. The body doesn't do well if you live just on broccoli either. You're not going to fare well health wise. You need all the things. But we have health guidance and health advice that gets distilled to very small or narrow recommendations, and certainly are not individualized. People are way too diverse as human organisms. I like to really remind people we are organisms, not something above the laws of biology. This is something that if you see someone declaring a general principle to all people, you automatically have to take it with a grain of salt. It cannot be true for everybody. There's no such thing, period. And I think it's really tough too when so much of the information out there is backed by, unfortunately, capitalism and people profiting off of human beings feeling scared and wanting to improve their health, because most people do value health in some form or fashion. Not everybody has to. I know that's a unpleasant reality, but I think that's a thing we physicians also get confused about. Of course, we value health. We went into the business of caring for people's health, but not everybody in front of us necessarily has health in their list of priorities. And they are more just wanting to live their life without someone moralizing or telling them their decisions are inferior or problematic with that guilt promotion. It's better to say, hey, let's talk about outcomes, consequences of choices. And what does that mean? What actually fits with your values? That's far more patient centered than it is model that previously existed. And now I've honestly lost where was I going with this? Food noise, like coming back to that.
We were trying to define clinically what is food noise. Now, in my preparation for this podcast, and I've recorded a few podcasts alone on food noise, there was literally 2 articles talking about food noise. They were all dating of 2023, 2025, because before that it was non-existent. And there is no clinical diagnosis for food noise. It's just observational thoughts that people are having about food. Is that correct? That's not a diagnosis. There's not neurodivergency on food noise, because I heard last week the people were trying to put a new diagnosis around obsessive food noises to justify GLP-1.
No, I think if anyone was to get into a true history of whichever individual is coming in front of them, there's very clear evidence of why that matters. Maybe it was the model of what their parents did in the household they grew up in. Maybe it's genetic, where they have a family history of eating disorders. Maybe it was weight stigma, where they were bullied and sent to fat camp in the 90s. And this is something they grew up thinking, if I'm not combating my identity as a fat person, then I'm doing something wrong and I am therefore wrong. So I have yet to meet a single person who is missing those historical components. They always have one or the other, or all of the above, let's be real. And that's really the underlying foundation of why they are so obsessed and preoccupied with thinking about food and measuring and even moralizing themselves around what are good choices. When we talk about the common parlance in everyday speech, people are saying, oh, it was so bad today, I'm going to have to work out so much more tomorrow. We normalize this in our Hollywood productions, in our social groups, in our family conversations around the Thanksgiving table. I don't know how many times I've heard, oh, I didn't eat all day so I could have plenty of space for Thanksgiving dinner. I'm sorry, everybody. For those of you that don't know, that is all disordered, period. That is disordered eating. That is not actually serving your biological entity that you inhabit in a way that optimizes function and health and well being. And so when your body has to go through prolonged periods of starvation, this is the outcome that happens. It is constantly scanning the world. And this is, again, isn't new. Ansel Keys, who I said I have a love hate relationship with, when he did the Minnesota semi starvation study and had completely healthy participants subject themselves voluntarily to starvation, so they lost 25% of their body weight. These were the psychological outcomes of that study. They had food preoccupation, food hoarding. They were more isolated. They were more distrusting. There was a lot that developed from that. And even after they were weight restored, a lot of the participants continued to have symptoms even 20 years later. This is not benign. Weight loss is not benign. Weight loss, I want to, again, be very conscientious. I'm not here saying no one should ever be allowed to have weight loss, because ultimately it is an individual choice that needs to be done between that person and their providers. But a provider who is not truly explaining the incredible and detrimental outcomes of intentional weight loss is biased in their medical care. And patients deserve better. They really do.
So how, as we think of food noise as this hunger, as almost, we want to talk about it as the fear system engaging, right? The body is afraid, not enough food is coming in. The physical hunger may be showing up. The mental hunger is showing up through food noise. What is the mechanism that then when GLP enters the body, the food noise, quote, shuts down literally overnight?
When you don't have your hunger cues, because again, you've slowed down gut motility, the gut is telling the brain, hey, don't allow any food to come in. We're not really moving things through. We need to like slow down, kind of like traffic control, if you will. Yeah, you're not gonna have that same push, and you're not going to fall into a pattern of obsessing over things you actually love, by the way. I think that's one thing that gets missed so much. Healthcare wants to pretend that we don't have a relationship with food as humans, but we do. We are actually wired to enjoy foods, have a broad interest in food. It's part of our social construct, even going back to, the times of tribes and nomads. And before we had any modern development, this was a communal component. So when you take out that emotional relationship and how it also transcends to other people and interpersonal relationships, you are fundamentally, again, interrupting what creates safety for the human organism. And you are triggering so much more fight or flight, sympathetic nervous system responses. It's not an easy experience to have. And yet, when people have a GLP-1, it takes a little bit of that work. It does provide relief from that mental noise, mental chatter that they think is the problem. They're just really misattributing what is bothering me, what is holding me back, what is keeping me from my quote unquote health goals. They make it a problem with their brain and their willpower when that's not it at all. It's a matter of how do we rewire as a culture and society to instead make eating, we say in the field, obviously intuitive, but just human.
Normal.
Eating should be human, be overly militarized and restrained and defined. Yeah, that's not living life. That's dieting. That's all it is, dieting.
Yeah, and it's also interesting because when you work a lot with general population, you will observe people who have dieting behavior for weight loss with food noise. And I also have a segment of the population, because I mentor a lot of professionals, they've evolved from dieting to now it's about health. And they still have the food noise, but the tune, the language, the words has changed from I want to lose weight to now I need to be healthy. So it's the wellness
we
culture
talk about
playing.
all the time. It's co-opting terminology that had very clear understanding and definitions and then blurring the lines This is why, when I talk about advanced psychopathology of eating disorders, I say it's not just about asking, what their goals are. You need to better understand why. So if someone says, I just want to be healthier, we have accepted that as a good statement from anybody for far too long, when really underneath it, there is so much more that's being lost in that pursuit. And this is where disordered eating becomes such a gray area. If someone is truly doing constant calculation of calories in, calories out, which by the way is not how the body actually works, it's false science all the way. I'm not going to stay off that soapbox for now. But if that's all someone's doing, they are still distracted from actually being present to their life and their relationships and their experiences and their other goals. That becomes something measurable, yes, and that can feel really good, to the human brain's need for dopamine. And that, I think that's another thing that's really contributing here that people aren't recognizing. We have watched society get more and more obsessed with immediate gratification. That's why, I'll be honest, I love my 2-day Prime subscription. Yeah, I love
The
my phone
phone.
that I can order my groceries, from my hand, and I don't actually have to go and worry about getting it. But there are trade-offs to what we lose when we also take on advances in technology. And I think this does feel almost humorously like Hunger Games, no pun intended. But when you watch District 1, I forget which movie it is, which part of the series, but they show them overly indulging and being gluttonous with their eating. It's, very hedonistic, but then they can take something and start over again. That shouldn't be a way of living that we normalize ever. And again, that is an extreme. That's not what I'm saying GLP-1s are doing, but this concept of I don't actually have to heal my relationship with body and self and food. Instead, let me just take this injection, this compounded medication, and I've been told that's all I need to be healthy. How reductionist, truly. It doesn't even make sense. It really doesn't. And people everywhere are duped, especially when you look at the data behind the GLP-1s. And this is one thing I love about the Association for Weight and Size Inclusive Medicine that I'm a member of the board of. And again, I know you had Reagan Chastain and her work is specifically digging into the critical eye, or with the critical eye needed to look at these studies and look at what's being put out from the quote unquote obesity side of things. It's so clear the conflict of interest is huge. There are huge groups of people actually benefiting from this entire escapade, if you will, of trying to make people in larger bodies thinner. That, again, can't be the basis of health, period. Redefining what obesity is around something vague and non-measurable and claiming it's about excess adipose tissue when you're never actually measuring adipose tissue to begin with should have been the clear indication that this was a completely flawed and BS issue altogether. And the fact that there are plenty of people in larger bodies who are not struggling with any health consequences at all, why is that not being included in the counter data of, oh, maybe we're trying to simplify the complex health issues of human beings as society advances, and we keep trying to reduce it to just being about body size. And why? Because we're
Well,
taught to.
oh yeah, and I think fat phobia, but also the interesting angle that I spoke with an emergency physician who treats a lot of incoming side effects of GLP-1, but she also identified something very interesting. People are afraid of dying. And because in our culture
Of course.
we've lost the spiritual health of the four bodies, that is no longer present in our societal ritual. People are afraid of dying, and she postponed the idea that it's part of the reason why people are latching on to like food, diets, restriction. It's like calming down our intrinsic fear of death. That's such an interesting angle.
Yes. No, I totally see that. I mean, we, at least in Western culture, send off our elderly to die in isolation. Very seldom is someone with their grandparent or elderly relative at the time of their passing. And it only dawned on me actually pretty recently. I was watching a preview of Michelle Williams' movie where she's a cancer patient, but she's meeting with a hospice nurse who is just hilariously overly enthusiastic about preparing to die in the last 4 weeks before your body dies and the signs that show up. And it was amazing because that's information that I didn't know.
No.
And I did look it up. It is legitimate.
Oh, yeah. And that
I think
physician
it
is
really,
also somebody who provide in Canada. It's interesting to parallel that, but you provide what is it named? There's a process where, not euthanasia, but where you can decide that it's the end of life for you. She provides that injection
oh,
and the care,
ooh, controversial topic. Yes.
but it's
We're not
available in
going to go there,
Canada. It's available
audience.
in Canada. So I want to bring another parallel to the food noise thing and talk about another trend I'm seeing coming up, body noise, right? The constant obsession with the body that people are having because of the fat phobia
Social
and body,
media.
right? Social media, fat phobia. And that is also tuned out when people are taking GLP-1. But again, food body noise is just the constant obsession about your look. It's not
Yeah.
that's not a disease or diagnosis that you can have unless I'm
I
missing
mean, there's
something here. Yeah.
body dysmorphia is when you see yourself differently than how you are actually in the world. And that has to do with a biological issue in the parietal lobe. So it's not a problem with the eyeballs, the optic nerves, or the occipital lobe. It's where the vision is given or the image is given meaning. And that it only happens to self because our relationship with ourselves is wired differently. I mean, for those of you listening, I'll be honest, I don't always listen to the podcast I'm on because I have that same reaction like anyone else of that's what I sound like. And the reason why I sound different in a recording is because when I experience my voice, I'm hearing it both through my ears, but also the resonance in my own head because it's from me. So there's a very different wiring of how we relate to ourselves, and that includes how we see ourselves. And we know that in eating disorder populations, body dysmorphia is huge. Unfortunately, it's also one of the last symptoms to heal, really, that because it becomes this driving pattern that keeps relapses so profoundly present. And it does eventually get better, but it's a really hard reality to swallow where you have to tell yourself, man, I need to remember that I don't see myself accurately. What I see is actually a projection of emotion and even self rejection. And so I see features that I've been taught to reject by society. When we talk about beauty standards, you know, the type of hair you have, what eyebrow shape you have, your nose size and shape, how tan is your skin if you're white, how light is your skin if you're dark. This is all driven by consumerism, truly.
Mm-hmm.
But it is deep in our core as humans. You know, when I look back, my grandma, for sure, absolutely, you know, through the 50s and 60s, she had one version of what beauty standards were going to look like. She was going to adhere to them. And she very much made sure my mom did too. And she wanted me to as well. I wish she was around now to still have this conversation, but I think she would say, what is it all for? What a bunch of bullshit, truly. And again, I would say more female oppression too, but we'll
Yeah.
get to that another time as
Oh,
well.
I have
But I
plenty
think,
of
you know,
podcasts on that.
I think it's interesting that you bring up body noise because what is really showing up is, of course, that's happening with social media and the interconnection of human beings on such a level that has never been seen in human history. Of course, people are scrutinizing their bodies more. Of course, people are fearing having any trait that is not the ideal, most desired trait. People that are short want to be tall. People that are tall want to be short. And yet, thank God, we don't have any procedures on the books right now to change their actual height, but yet weight becomes that one metric that is seen as optional. And that sucks. It just sucks for everybody.
When you think about body dysmorphia versus body noise, when we look at treating body dysmorphia, correct me if I'm wrong, but it's CBT, right? Cognitive behavior therapy is the golden standard of that.
So the data around what is the gold standard modality, I will admit, It's more gray than that. And really, for individualized care, the best approach is, what is the patient grabbing onto?
Yeah.
What, version of a reframe or a rewrite, an interruption, a distraction, a coping skill gives them the most relief so that things can start to have
Okay.
traction. So, yes, CBT is one, but also exposure, ERP, exposure
Yes.
response prevention. That is the gold standard for OCD. OCD can be classified, for some as intrusive thoughts and difficulty discerning reality, and it causes distress. It's not something that feels good. So ERP can be really helpful here. And also, even going as far as, okay, I'm trying to think, like, I'm worried I have too many freckles.
Yeah.
Like, maybe you don't, but why is that something to be this stressed
Yes.
about? It's really, that's where the CBT cognitive component also comes into play. I think what helps a lot of people move away from their obsession with body features is actually act. So this is where you're looking at both radical acceptance of what is, but also really looking at, how does my life align with my values? And that starts with even figuring out, what are my values? You can go through 100 different words, and it's not just health or relationships or independence. There's so many other
Yeah.
components too. Honesty, integrity, success, even, there's no judgment or moralization of these, but really figuring out, what are my 5 main tenets that I want to utilize as a litmus test for my decisions and my goals in life. And that's when you realize, oh, this was so much more superficial than I ever gave it credit
Yeah.
for. It felt real and necessary, required to be a good human, but wow, I don't have to be this way. So that shift alone can be really freeing, truly, for people that are
Yeah.
struggling with, in this case, body noise.
So we talked a lot about body noise. I want to go back to food noise and put it in parallel to treatment of eating disorder, because there's a paper that came around my circle of influence that talked about treating binge eating disorder with GLP-1. What are your thoughts on that?
I mean, it makes sense that someone decided to look at that because they're thinking, oh, this is food noise related. But again,
Yes.
the root of binge eating is restriction. That has been proven over and over again. So, yes, there might be this one paper that says, oh, this works to treat binge eating. But why would we not still be trying to treat the initial start of a binge eating
Yes.
issue? And it's restriction. Again, why are they restricting? They've been taught to do. That's what they were moralized to believe is the right thing. They, wanted to, quote unquote, get healthier after a breakup. Who knows? There was some emotional thing that happened, and they started restricting what they were eating. And again, mental and literal restriction makes you want it more. We already went through that entire reward
Yeah.
pathway hijacking, and then shame and guilt response that just further perpetuates it. So, no, at the end of the day, eating disorders are actually a manifestation of psychological state more than being something existing independently. There is either, that need for control and that need for something measured, the really analytical type A, highly functional, high achieving individuals. They usually fall into eating disorders. The individuals with really big feelings and not a lot of guidance on how to handle them, and they internalize it all, that turns into eating disorder pathologies, but it's never in isolation. And that's where it can't exist to just say this one treatment will cure this. No, you have to cure the foundation, the soil where the eating disorder behaviors grew from, and understand more of why the patterns are there to begin with. Yes, helping someone get out of malnutrition and all of the mechanics that happen in the body as a result of malnutrition, which, by the way, for those that don't know, you are actually likely experiencing malnutrition if you lose 10% or more of your body weight in less than 3 months.
No.
So, that's not what most clinicians are taught. They're
No.
taught malnutrition is only a thing to worry about if someone has autonomic instability, like their heart rate, their blood pressure, their body temperature is problematic. They're having low glucose, like, oh, those people are probably malnourished. No, the truth is your brain shifts into starvation mode and protection of the body to try to prolong life as much as it can when it experiences rapid weight loss. That is just 10% in 3 months or less. So we have a lot of people out there who are at a high risk for this. And what's really interesting is how no one talks about 35% of people who pursue intentional weight loss will develop disordered eating. So the binges, the preoccupation, the life, gets completely blown up structurally and is only around food. And 20 to 25% of those individuals will develop clinical eating disorders. In between there, though, the sub-threshold diagnoses that actually could be created, they exist in a very large way, but they're not taught exactly because how do you monitor for that? People are not checking. So the prevalence and incidence metrics we have and statistics are not actually indicative of what's happening in real life. And especially with GLP-1s on the market now and as rampant as they are,
Yeah.
I know this is just going to keep going up. So, how do I reframe that for myself? I guess I have job security, but it doesn't feel good.
That's what I said to so many
feel
people.
good.
I'm like, for me, I'm not afraid of GLP-1. That is job security because people will come off of them at some point. The majority of people will
Correct.
end their relationship with GLP-1 and they're going to come and see me because the problem was
Yeah.
never the first place.
Exactly. And when people don't lose dramatic weight like they thought they wanted to or needed to, and again, society is still society, it's not enough to avoid discrimination. What's the point in feeling like crap all the time? That's just one narrative of many that are going to happen.
Since you're a pediatrician, I'd love to have your thoughts
Mhm.
on children and GLP-1. I haven't talked to anyone
Mm.
around this. And it's not the audience of the podcast, but we have many people listening to the podcast who have children. What are your thoughts on the
Yeah.
prescription of GLP-1 to children and adolescent, I guess? Young people.
Okay. I'm going to try to make sure I don't get too emphatic here. When the American Academy of Pediatrics came out with their new clinical guidelines in 2023, honestly, I was appalled. They did a nod to weight stigma, a nod to eating disorder screening, but ultimately saying this is a viable and clear option to help children in larger bodies, sometimes down to age 10, and that includes bariatric surgeries, by the way. I was beside myself. Because at the end of the day, this is again out of fear. People assuming that a fat child is going to be a fat adult. And we've demonized being a fat adult so profoundly that we're interfering here when kids are not little adults. They are growing and developing at completely different rates and have completely different needs. And weight loss at their age is catastrophic, not only from development of identity and self. You've now told them there's something wrong with my body, and you're setting them up to have a medical treatment that will interfere with their engagement with life. I mean, have you ever met an 8-year-old who's nauseous or even a 14-year-old who's nauseous all the time? They're awful because they don't have good emotional regulation skills and they don't have abstract concept understanding to necessarily tolerate it well and justify it. So saying a kid is worth, having not only physical symptoms, but then likely social implications and detrimental outcomes following it for the sake of just having them lose weight, which again, we already said is the wrong metric to aim for altogether, is horrible. I think what's lost so much is whatever happened to the fact that we could celebrate cute fat babies with lots of rolls and we can feel really good about it. Kids need those reserves too for their height potential. So if you start making them lose weight, they're not going to grow the same way they would have before. You are literally causing height suppression. And I have this analogy where kids, when they're growing, they're like Play-Doh. So if you want to roll out a long snake, the first thing you're going to do is roll a ball.
Yeah.
It's shorter, it's squatter. I don't know those. It's squat and short, right? But that doesn't make it wrong. Now, when you roll it out, it can be a nice long snake that is sturdy enough to not break the moment you pick it up. And I don't know why that got lost. I don't know why this was deemed appropriate. I mean, I know I've worked on a reply with Reagan Chastain and several other clinicians to better delineate why this is so harmful. That it really does ask the question, who's behind this recommendation? And what really sucks the most is even if the AAP issues some sort of recanting of this article of 2023, the damage is already done.
Yes.
Clinicians that are out in more rural areas, away from academic centers, they rely on AAP treatment guidelines to keep them current in how to practice medicine. So it's going to take at least a
Years.
decade, if not longer, yeah, to completely undo the installation of this update that they did. But no, absolutely not. Weight loss is not appropriate for any developing child, period. Adults have their own prerogative, their own ability to consent. If they're over the age of 25, they technically have a fully developed frontal lobe. But anyone else, no, they cannot truly consent or assent to that treatment, nor should parents be guilted into doing the treatment themselves, or consenting to it
Yeah.
themselves.
In a child who is being prescribed GLP-1, when the guideline was given to pediatrician, is there any research that looked at the consequence of weight loss and or GLP-1 in children, or there's zero data to support that?
That's a really good question. I think this is where I
because I
sometimes,
can't remember
have to
Reagan
admit,
talking about looking at even people below 8 data.
no, and even in bariatric surgery and GLP-1
Yeah.
research that are supporting the use of these treatments, again, they're not long enough to look at those long-term complications, but it's more of anecdotally, I
For
see
sure.
those patients, you see those patients,
Well,
maybe
I
lots of other
see.
people see them, but they see it as adults, like what happened as adults.
Yeah, I see them at 40. That's my age group, like 40 and above, when they're going through the menopause change and they're like finally ready to deal with it. And now clients out of 10 will tell me I started dieting at 8, 9, 10, 12 years old. That was my first diet. And
Yep.
they carry that up to like 40, 45 when they're finally ready to do the work on that.
Yeah, I mean, we're talking about imprinting on a new soul, a new human at such a young age. No wonder this is a constant obsession for them because you were taught to obsess about it. And, this is the same thing as, a phobia or an aversive reaction or experience that happens at a young age, causing problems psychologically throughout life. This is no different.
Yeah.
A child, again, has new wiring that is getting put into place. And if the wiring is guided around this issue and rejecting their body, rejecting the size that it exists in, and constantly looking for an external influence to control their body, how can they have an appropriate relationship with their own existence? They can't.
Yeah, because their identity is built around, quote, not being enough, needing to be different,
Mhm.
needing to control food. So all the rest of the brain wiring is built around that identity.
And then you also have cognitive bias where it looks for reasons that or examples that affirm that conclusion, even if there's so many other examples that could have been considered. They're not picking up on that. Their brain doesn't do that. And so this is where, again, the biggest issue or the flaw of this whole approach is still assuming we have the right aim, and we just don't. And I don't know why even well-intended pediatricians keep forgetting, because they know that kids are not just little adults. They know how different they are. There's a reason there's an entire different residency
Field.
program for kids than there are for adults, period. But yet somehow everyone's been duped into thinking I am doing the best thing for my patient. I actually, unfortunately, had a pretty heated debate with a former colleague of mine who I supervised in residency. And I was just trying to explain why the BMI should not be a metric for treatment decisions and clinical decisions. And, he ended up saying, I know what I need to know to help my patients. And that was it. And it really it's just tough when you have a combination of ignorance, and I'll admit, maybe some arrogance. Even the best people can sometimes feel a little guarded around their own
Oh, yeah.
knowledge and expertise. But that is arrogance at its worst.
And internalize weight stigma or fat phobia, their
Absolutely.
own
Yes.
fear of fatness. Like
Yes.
surrounding those two things is what's so arrogant about it and
Yes.
certain.
Yeah. That they can't incorporate the data that shows this is not good, period.
As
It shouldn't be
scientists,
hard to debate that.
and I want people to listen to that, even if you're not a professional, recognize like those people have been trained for 10 to 12 years in science. And the
Correct.
internalized fat phobia weight stigma is so strong that it overrides their 12 years of scientific training. This is powerful
They have
shit.
selection bias. Yes, it is.
So for us as individuals, remember that power is also in how we interact with ourselves. Like it is as powerful in our own day-to-day life that it is to override those 12 years of plus of scientific training for physicians.
Yeah, totally. And that's why people who do work with eating disorder patients have to be intentional too about making sure they explore that. I mean, I get asked all the time, why eating disorders? It's not because I actually had my own. I do know a lot of people who were close to me that struggled, but I am a person in the system. And, what really got me into eating disorders was, again, a nerdy fascination with this biological, psychological overlap and the family dynamics and the system dynamics. I mean, I just thought this is such a complex problem. This is what I want to do with everything. My own psychiatrist has joked, why do you want such a
Why?
challenge? But here I am. But truly, I was a sorority girl in college. I absolutely participated in my hospital's, biggest loser competitions. Why? Because it felt like it was supposed to be, that was just what you're supposed to do. And I grew up in the 90s and the 2000s where Biggest Loser was a real thing, the Swan. All of our entertainment was around physical changes as the goal of life, when really, oh my gosh, what a reduction of what our purpose on this planet is as human
Yes.
beings.
Yes.
And, my favorite awakening, if you will, was when it became so clear, and a patient actually helped call this out. And now it's talked about so much more in the field. It's almost embarrassing to admit. But the concept of, we used to reassure patients who were going through weight restoration care, you're not gonna be fat. Like that's right. That's your biggest fear. And it's not going to happen because your ideal body weight is X. And there's no way that's going to have you in a fat body. Oh my gosh. The fact that we were just reaffirming that global concept of size and not wanting to be in a size. Oh my gosh. But the moment I understood that and connected my neurons, oh my gosh. It's my favorite thing to now talk about in a different way with clients and patients. And truly, even saying, but if health is what you get, why are you fearing this? It should have no consequence, truly. And what you're really fearing is discrimination from other people. And the last thing you want to do is discriminate against yourself. I mean, if someone had cancer in their leg and they're told they have to have, an operation to remove their leg, an amputation completely, then, they will say, yes, obviously, and yes, they're going to have to go through life now being looked at with, why does that person have only one leg? My own kid said this to me in the Stop and Shop yesterday. And I was like, something happened medically that they needed to not have a leg. She said, but it's different. I was like, yeah, people have different lives. I find it fascinating that reclaiming health and reclaiming vitality and longevity still feels like something not worth it if it means being in a larger body than what their eating disorder wants them to be in. And it just,
I think you
that's the
hit the
extreme.
word though, but you hit the word different. Like I'm going to start a program just on the art of being different because
Yes,
I
why
think
do we have to be the same?
but I think it's wired in. It's wired into the human to
Yeah.
not be different. So as soon as we're different for whatever reason, size, body, color, whatever, like we engage into our safety mechanism to wanting to align with the group.
Yes. It makes sense because from an evolutionary perspective, the biggest risk to
Yes.
human beings was being isolated and not belonging. And our fear of not belonging is still very strong. I mean, it's wild. Really. So I think you nailed it
Fundamentally,
as well. It is about difference.
that's why GLP-1 is so popular, because it's an easy, quick fix to solve our differences with the world. Like, just inject. I have nothing else to do, and I'll be the same as the rest of the world, be thin, and I'll be
Yeah.
presentable. I
But
want,
here's the thing that worries me the most.
yeah,
I have one more point that worries me
go
the
for it.
most. Again, we don't have long-term studies showing the outcomes. We have nothing longer than 5 years, people. But here's the thing. If we know that rapid weight loss causes starvation in the body, and we know that people on GLP-1s are suffering with sarcopenia, meaning loss of skeletal muscle, there is a point in the human lifespan where you don't build muscle back. You can't.
Yeah.
And that happens around 70s, 80s. It's a little different for everybody. So if fall risks in your 80s and 90s and a broken hip is the number one risk for death, like, you're likely to not live very long once that accident happens. What do we expect to happen to the lifespan of people who have signed up for GLP-1s, who now have loss of skeletal muscle, so don't have as much strength going into their phasing out, if you will, and body breakdown. And now their bones are more brittle because malnutrition causes osteopenia and then osteoporosis. You're going to have a whole lot more devastating outcomes as people fall more and die earlier. And
And
unfortunately, we're not going to have data on that until 20 years from now.
I'll add one more angle: mental health issue, mental health
Oh,
diagnosed, anxiety, eating disorder. I
totally.
mean, like, this is just going to go rampant in 5, 10 years. So that's my closing question. When you think about 5 to 10 years from now, and you think about
Yeah.
our field of weight neutral health, what is your prediction, or what is your outlook?
Oh, I mean, I think it's very clear. There's so much concern for why are people more unhealthy now. I actually think it is the mental toll and the mental load of being a human in today's world. We are stretched beyond our capacity. We really weren't supposed to be in such a global, huge data reception existence. We were supposed to only know 150 people and have pretty routine, consistent roles and responsibilities. I mean, I think about my generation of women right now. We were raised, on the heels of feminism coming into the workforce, and no, you don't have to be a stay-at-home mom. But now here I am trying to work a full-time job and still be a full-time mom. You know, no wonder I'm like spinning when I try to go to sleep. This is real. And I like to be real with my other peers and cohorts, both professionally and in my work. Like, this is real. Your anxiety and difficulty sleeping
Real.
is not necessarily a you issue, it's a societal pressure issue. And so I do think, again, knowing, as you just said too, what the outcomes were of the Ansel Keys study, what I see every day in clinical practice for people dealing with eating disorders, and how at first it offers relief from intolerable emotions, but ultimately increases just how intense they all are. We are, unfortunately, and this is not to be dramatic, but there is a level of doom, I feel, of how can we turn this around? How can we actually protect our humanity and our interconnection and our sanity too, when the noise of everything else that's demanded of us and told to be a priority just keeps getting louder and louder? I don't think we're going to fare. We are breakable. We are not infallible. We're not superior beings that can control everything. I think that's still what drives me crazy, is so much of medicine originally was to solve, health problems, but now it seems, can man master the body instead of working with the body and realizing how incredibly, adaptive and brilliant our body is at protecting us from the decisions we make to. It's really amazing. Like, why does someone gain 10% more after they've gone through intentional weight loss? Because the body doesn't know that was self-inflicted. The body thought, oh, there was a famine around my human. I want to make sure that if another famine shows up anytime soon, I'm ready and I'm prepared. So every single person who has ever been subjected to intentional weight loss, they have a curve that looks like this. So again, if everyone is saying, oh, but see, fat people are the problem, you're fat, you're unhealthy, what if we actually called out your body size at this moment was never your natural set point? It's what happened after you had harm caused to you by intentional weight loss goals as the number one thing. I mean, it's so unfair. It's just so unfair.
My outlook is that I think we've optimized the body as much as we can, like from a health perspective. I believe that the future is weight neutral health, because how much more optimization, right? How much more optimization can we do? And the solution is going to be weight neutral health, where we talk about health without talking about weight. That's the simplest way of explaining it.
Yes. No, I love that you're bringing it back to that. And instead of just going into my forecasting doom and gloom, yes, that is the answer. Absolutely. To protecting mental health and physical health, especially when we already have data that shows non-inferior. I hate that people had to even skip around the fact that weight neutral approaches actually have the same outcomes as far as improvement of blood pressure, improvement of hemoglobin A1C, improvement of energy and function, and participation in life. Why are we downplaying that? Because there's a bigger bully in the room, unfortunately, with more money than any other industry behind them.
Before we end this conversation, I want you to talk to us about the food noise reality roadmap, because I think everybody on the go and grab it from your website.
Thank you. That actually was my attempt at catching people that I know are looking at their health from one paradigm and need to be re-educated. So it's a free resource that allows people to really explore the questions we talked about here. Where did this come from? Why is it here? And better explain the neurobiology behind it and really ask those questions. Is this really a problem that you need to address, or is there something else worth addressing? And so it's a 5-day free email course. You get emails from me. You can reply directly to me. And then truly, if you need more support, happy to offer options. Of course, varies one option I'd love for someone to consider, but we also are here to collaborate with other providers. And we absolutely refer to anyone and everyone that we have already verified is a good person to guide someone's health journey. So yeah, check it out.
It was an absolute pleasure. And I think we have so much more in common.
Thank you. Thank you. It was a pleasure. Thank you for inviting me.
Want to coach behaviors, not bodies? Learn the mindset tool and the method that create real changes? Join the waitlist for the next cohort of the non-diet coaching certification at stephaniedodier.com/waitlist. That's where the real training begins. And I'll see you on the other side, my sisters.